Hi everyone, welcome to this episode of Crit Care Bites, where we interview experts in the field to distill clinical pulse and wisdom around critical care topics. My name is Chairman. I'm an intensive care trainee and I'll be your host. Today we have Dr. Jason Phua to share with us about mechanical ventilation strategies in ARDS. So to start us off, Dr. Jason, perhaps you could share with us about the indications for mechanical ventilation in ARDS, perhaps in light of the potential options for less invasive treatment like high flow nasal oxygenation or traditional NIV.
So the most important and commonly used indication for ARDS would be the severity of hypoxemia. Of course, we also look at other factors clinically, whether the patient is just extremely tachypnic, whether the patient is drowsy, whether the patient has got non-pulmonary problems like hypotension, metabolic acidosis. So all of the above would be triggers for me to consider mechanical ventilation. So back to the first thing I said, the severity of hypoxemia. So if we go by the PaO2 to FiO2 ratio, anything less than 300 is ARDS, and it would be time to think of mechanical ventilation. But that is still relatively mild ARDS. So moderate ARDS would be PF ratio of less than 200, and that would be really time to consider mechanical ventilation. If we translate that to in actual practice, what does it actually mean? It will mean that you have a patient in the emergency department or in the wards or in the intensive care unit, and you need to give supplemental oxygen to keep the saturations at 92 and above. And you find that you are running a venturi mask of 40%, 50% in order to achieve that kind of saturations. That would be the hypoxemia territory to start to consider some form of increased respiratory support. For sure, if you find that you are requiring a non-rebreather mask to keep the saturations above 92%, that would clearly be a trigger for you as well. But we talk about mechanical ventilation as if we should only think of invasive mechanical ventilation. However, there are other possible means of respiratory support. And one would be non-invasive ventilation, where we give pressure through a mask, and the pressure goes up, and the pressure goes down, and the pressure goes up, and the pressure goes down. So that's NIV. Two would be continuous positive airway pressure, where the pressure doesn't go up and go down, it's just a constant pressure, and that's called CPAP. And three would be high flow nasal oxygen, where we use extremely high flows of initially 50 to 60 liters per minute of oxygen through the nose, and it creates positive pressure as a result. It also removes carbon dioxide because of the washout, and is moisturized, and so the patient can tolerate it, and that's high flow nasal oxygen. So even though I did say that these thresholds of the PF ratio of less than 200, worsening hypoxemia, you would consider mechanical ventilation. I think in this day and age, we would first think, is this patient suitable for non-invasive ventilation, CPAP, or high flow nasal oxygen? If there is no other non-pulmonary complications, the patient's not drowsy, the patient is protecting the airway, the patient doesn't have severe metabolic acidosis, the patient is not hemodynamically unstable, it is actually not wrong, and in fact I would say right to consider the use of these alternatives. Only if these alternatives fail, then do we consider invasive mechanical ventilation. And what do we mean by failure? For example, high flow nasal oxygen, you put it on at 50 to 60 liters per minute. You put on whatever FiO2 is needed to keep the oxygen saturation at 92%. And you find that despite putting it on for an hour, the patient is extremely tachypnic. I would consider that a failure. Alternatively, you put it on at a high flow rate of 50 to 60 liters, and you find that you are consistently having to max out the FiO2. You are requiring 80%, 90%, even 100%. I would consider that a failure as well. There is a score known as the ROX score, where we have the SpO2 divided by FiO2. That is a ratio. And this entire ratio, we divide it by the respiratory rate. So the numerator would be the SF ratio, which basically says that how severe is the hypoxemia. The denominator is the respiratory rate, which basically tells you how severe the tachypnea is.
Yeah.
And if the ROX score is high, it means that the patient is not so hypoxemic and relatively comfortable. Probably don't need to intubate. If the ROX score is low, the patient is very hypoxemic and extremely tachypnic, probably need to intubate. So we have these different scores for NIV as well. And essentially, we can use a combination of scores versus just clinical impression. Is the hypoxemia worsening? Is the tachypnea worsening? And if we fail, then there will be an indication for invasive mechanical ventilation.
Okay. And practically between high flow nasal oxygen versus like continuous positive pressure, how do you decide your modality of non-invasive mechanical ventilation?
Yes, there is evidence-based medicine and there is reality on the ground.
Okay.
So the last 2.5 years of COVID, we have seen a lot of changes to the medical literature as a result of COVID. So for example, there are studies such as the Hannibal trial, the Recoveries ARDS trial, the high flow COVID trial. These studies, to very quickly summarize, pitted 4 different modalities, not all in one study, but in different combinations and permutations. Conventional, which means just nasal prongs, venturi mask, non-revealer mask, followed by intubation. High flow, non-invasive ventilation, and CPAP. I must say that for ARDS, even pre-COVID, but especially for COVID, when we talk about non-invasive ventilation, the more stronger evidence is for NIV through what's known as a helmet. It's a big tank, and you can actually turn your head around, as opposed to the face mask, which is what many of us are used to. Very simplistically, and I'm just saying this because we want to summarize this, right? Very simplistically, the evidence in 2022, especially for COVID, is strongest for some kind of positive pressure through either a helmet NIV or CPAP.
Okay.
Followed by high flow nasal oxygen, followed by conventional. It is very likely that NIV through a helmet, CPAP, and high flow nasal oxygen, very likely for more severe patients, can reduce the need for intubation. What we don't know is the impact on mortality.
Okay.
So that's good enough for most of us, reduce the need for intubation. That's evidence-based medicine. In reality on the ground is what kind of machines do we have? For example, we are speaking from Singapore, and to the best of my knowledge, only one ICU in Singapore has the helmet. And so face mask NIV is not evidence-based medicine for non-COVID as well as COVID ARDS.
Okay.
Many of us who are speaking from Singapore are extremely comfortable with high flow nasal oxygen, and so are our patients. And so even though the evidence for COVID specifically is stronger for helmet NIV and CPAP, many of us still use high flow nasal oxygen. There's some data that it can reduce intubation, and I think that's a reasonable approach.
Okay, thanks, Dr. Jason. So now perhaps let's say we've made the decision that this patient requires mechanical ventilation. So what are some of the broad principles when we approach mechanical ventilation in the context of ARDS?
Yeah, so we mechanically ventilate patients, and I'll zoom into the invasive ones. We mechanically ventilate patients to try to save their lives, right? We don't want them to die of hypoxemia. So a lot of it is to use the positive pressure to recruit the lungs. reduce the shunts to improve the oxygen, and meanwhile, reduce the work of breathing because the machine does it for you as opposed to you huffing and puffing away. But we must always remember that mechanical ventilation itself can cause ventilator-induced lung injury. When we talk about ventilator-induced lung injury, we generally differentiate it into volume trauma, barrel trauma. I say the two of them together because they are part of the same thing. Volume trauma just means giving too much volume, and pressure, barrel trauma means giving too much pressure. It's the same thing because if you give too much volume, you give too much pressure. If you give too much pressure, you give too much volume. And these injure the lungs. Number two, athalec trauma, where your mechanical ventilation results in recruitment of the lungs transiently, but then there is deflation of the lungs as well when you go into the exhalation phase. And this inflation and deflation does cause mechanical stress and shear of the lungs, and that causes lung injury as well. Volume trauma, barrel trauma, and athalec trauma result in a release of cytokines, and this is biotrauma, and that injures both the lungs as well as causes multi-organ failure. So ventilator-induced lung injury is actually a cause of ARDS. It is ironic. You intubate a patient to help the ARDS, but if not set correctly, the ventilator can worsen the ARDS. And so the principles of mechanical ventilation is, number one, as I said just now, yes, you need to give enough support to help relieve the work of breathing, to help mitigate the hypercapnia, and importantly, to improve the hypoxemia. But number two, we need to be sure that we do not cause barrel trauma, volume trauma, or at least we do not cause as much. We minimize the risk of this. We minimize the risk of athalec trauma, and we minimize the risk of biotrauma. So very often, as we say in intensive care, even for invasive mechanical ventilation, less is more.
Okay, thanks, Dr. Jason. So now maybe moving on to the practical aspects of using invasive mechanical ventilation. The patient is intubated and put on the ventilator. Using the principles that you have just mentioned, how do we translate them into the initial settings that we put on the ventilator, and how do we then titrate them subsequently?
Yeah, okay. So we imagine we have just intubated the patient. And depending on your preference, your practice, you would set either access control, volume control ventilation, which is volume targeted, or access control, pressure control ventilation, which is pressure targeted. Right? Both are fine. And then let's go into 4 different things. The first thing I would say is respiratory rate. Second, tidal volume. Putting it relatively simplistically, this, because respiratory rate times tidal volume is minute ventilation, this would determine your carbon dioxide. And then you think about number 3 and number 4. Number 3 is your FiO2, and number 4 is your P. And putting it very simplistically, this would increase the mean airway pressure, and this would be the ones that affect oxygen. So what do you set? So respiratory rate and tidal volume first. You have just intubated the patient. Minimum respiratory rate, I'm going to talk about ARDS, right? Please don't confuse this with asthma or COPD. We're talking about ARDS. Minimum 20, minimum. It also depends on how tachypnic the patient was before you intubated the patient. It also depends on whether there's an associated component of metabolic acidosis. Because if there is metabolic acidosis, the pH would be lower than just based on respiratory acidosis. So if you're not careful and you have a patient that was hyperventilating away like hell before you intubated the patient, he's got both ARDS and septic shock with lactic acidosis. The bicarb is 10. The pH was 7.1, even before intubation, right? And if you're not careful, and you remember minimum 20, and you intubate the patient, and you put a respiratory rate of 20, you have effectively at least half the minute ventilation because he was breathing at 40 to 50 before that.
Yeah.
And before you know it, the pH would have crashed to 6 point something, and the patient will die. And so for selected patients, tachypnic like hell, low pH, severe lactic acidosis, it's not wrong after intubation to push the respiratory rate up to 30, and then take it from there. And then I go on to tidal volumes. The very famous study from the ARDS network, published more than 2 decades ago, it's called the ARMA trial, has shown us that prevention of volume trauma by limiting the tidal volume to 6 mils per kg predicted body weight, as well as prevention of barotrauma by limiting the plateau pressure. Plateau pressure is just the end inspiratory pressure of the alveoli to less than 30 cm H2O, can reduce mortality. And as such, when we first intubate the patient, we just set whether it's volume control or pressure control to target a tidal volume of 6 mils per kg of predicted body weight. And predicted body weight is based on height as well as gender. And then we go on to FiO2 and PEEP. Of course, when you first intubated the patient, it's easiest to just up the FiO2 to 1.0. Now, what PEEP do you use? It depends on several factors. There are patients that are really under-resuscitated from the volume standpoint. They are hypotensive. They are still extremely dehydrated. For whatever reason, we haven't actually topped them up with the fluid beforehand. And so these patients, you don't want to ramp up the PEEP too high. I would say, depending on the degree of hypoxemia, somewhere between 5 to 10, maybe 5 to 10. But if you're not worried about the hemodynamics, it then depends on how severe the ARDS is. We have something called the FiO2 to PEEP table, where in order to target the oxygen saturation of, say, 92 to 96, we have a certain amount of FiO2, and the higher the FiO2 is, we have a certain amount of PEEP. So we can follow the FiO2 to PEEP table. And so, for example, if the patient is on FiO2 of 1, often you need to give a much higher PEEP than a person with a lower FiO2. So that's the initial settings. How do you titrate them subsequently? In reality, what happens is that you set the initial settings. You then maybe start to insert the central lines, do whatever else. And during that time, you have a pulse oximeter on. And you can rapidly adjust your FiO2 to PEEP according to what I just said, the FiO2 to PEEP table, to keep the sets somewhere between 92 and 96. But you don't know what the carbon dioxide is. You don't know what the pH is. So half an hour later, you will check a blood gas. And that is when I would target a pH of 7.25. So if the pH is 7.25 and above, things are cool. We don't need to muck around. But if things are less than 7.25 and the respiratory rate is, say, set at 20, I would then up the respiratory rate to try to target a pH of 7.25. We don't increase the tidal volume in order to target the pH. We increase the respiratory rate because borderline excidemia has never been shown to kill patients, but high tidal volumes and high plateau pressures have been shown to kill patients. So we work along that. The last thing I would say is that even though I did say that we have this FiO2 to PEEP table, the titration of PEEP, nobody has a very strongly evidence-based method of doing that. We still need further studies. FiO2 to PEEP tables are almost cookbook. They assume that if you have severe hypoxemia, you would respond to higher PEEP and vice versa. but it is not true. There are patients with severe hypoxemia that do not respond to high PEEP and vice versa.
Yep.
Personally, even though those tables do tell us that for a patient who's going on as high a FiO2 of 0.8 and 1, the PEEP can go to crazy amounts like 18, 20, 22, even 24. I never do that. Personally, based on some evidence, meta-analysis of 3 big randomized controlled trials, that for more moderate to severe ARDS, we need a higher PEEP. And for mild ARDS, we don't need the higher PEEP. Because of that, I do give a higher PEEP for moderate to severe. But when I say higher PEEP, I do not breach 15.
Okay.
And many people do not breach 15. So we are talking somewhere between 12 to 15. And when we say lower PEEP for the milder ones, we are talking somewhere between 8 to 10. So those are the ranges that I follow.
Okay, thanks, Dr. Jason. So just a quick practical question on the issue of plateau pressure, right? So in the context of a volume-controlled ventilation, then we achieve that with an inspiratory pause. In the context of a pressure control or pressure-limited ventilation mode, the plateau pressure, how do we derive that?
It depends on your ventilator. So regardless of ventilator, what happens when we measure the plateau pressure is that there is a certain amount of PEEP, and then there is an inspiration, and the air goes in. And when the air goes in, the pressure that is measured increases. And this pressure has got 2 components. The first component is pressure that is from the airways as air is going in. It depends on, number 1, the flow rate, and number 2, the resistance of the airway. And then the second component is got to do with the lung component, the alveolar component, the respiratory system compliance component. You know, it reaches the alveoli. And this depends on, number 1, the tidal volume, and number 2, the compliance of the respiratory system. The machine, regardless of brand, would then do a pause where there's no more airflow. And as a result, the pressure does drop. Why does the pressure drop? The pressure drops because there's no more airflow. There's no more contribution of pressure from the airways. And then it plateaus out because there's a pause. Air doesn't go in, air doesn't go out, and it plateaus out. And that plateau out pressure is a reflection of 2 things: the tidal volume as well as the compliance of the lung. So the classic way of doing the end inspiratory pause maneuver is, regardless of whether you are on volume control or pressure control, you would switch the patient to volume control. In order to stabilize the flow rate, you would change the flow waveform from a descending ramp waveform to a flat waveform. And then you will press the button and the machine would then measure the plateau pressure. And because of mathematics, often the machine would then also tell you what the compliance and what the resistance are. That's the classic way, but increasingly ventilators are smart, and regardless of whether you're on pressure control or volume control, there's just this one button that you can press and it will derive it for you.
Okay, understand. Thanks, Dr. Jason. For the next question, I think you've answered most of it in terms of the targets. You mentioned that for an SpO2 target, we usually aim for 92 to 96%, and we give some element of permissive hypercapnia with a pH of accepting anything above 7.25 and a plateau pressure of less than 30. Are there any other important targets or numerical values that we look at when we mechanically ventilate patients with ARDS?
I think look at the patient. Really look at the patient, because these are just numbers. There are patients with a respiratory rate of 24. Seems fine, but actually they are just using accessory muscles, just huffing and puffing like crazy. These patients may need a bit more support. Have we not given enough PEEP? Maybe the lungs are de-recruited. Do we need to give more sedation? So number 1, look at the patient. Number 2, look at the patient and the ventilator, because there is a very, very, very painful thing known as patient ventilator asynchrony. You get all the different types of asynchrony, such as flow starvation, double trigger, ineffective triggers. That would take an entire maybe workshop to talk about. Yes, the targets for mechanical ventilation would also include trying to minimize asynchrony. And then there are many other things that I don't think is in the scope of today's discussion that are still being studied. For example, driving pressure. Driving pressure is mathematically the plateau pressure minus the PEEP. And there are indications that that could be an important component of ventilator-induced lung injury. So if you want a number, we should try to keep the plateau pressure minus PEEP less than 14 cm H2O. There's also increasingly talk of something known as mechanical power, which is basically a combination of everything in the ventilator, right? Everything. You're talking about respiratory rate, PEEP, flow rates, peak pressure, etc. Everything. And there's also a mathematical formula. And the idea is that this particular number is a combination of everything that can cause ventilator-induced lung injury. And we want to try to reduce the mechanical power to reduce the ventilator-induced lung injury. So things like driving pressure, things like mechanical ventilation being studied. We have to watch the literature, but today, for most intents and purposes in ordinary clinical care for residents and all that, I don't think we need to dwell too much on this yet.
Okay, thank you. And finally, for the last question, at the beginning, you mentioned that we have the liberty to decide whether pressure control or volume control, but does it matter in any practical sense? And how do you decide usually?
There is one study that long ago suggested that modes matter. Okay. But increasingly, the impression is that they don't. And the reason why I say that is because pressure control, if set right, can look like volume control, and volume control, if set right, can look like pressure control. Barotrauma is just another way of looking at volume trauma, and volume trauma is just another way of looking at barotrauma. So for these reasons, it probably doesn't matter. In reality, on the ground, and I suppose this is the case in ICUs everywhere around the world, what is used depends on the familiarity and the preference of the clinician, the nurse, or the respiratory therapist. For myself, because I want to make things as easy as possible, right? And the patient has just been intubated. The patient is on sedation. Initially was given some kind of neuromuscular blockade like succinylcholine, rocuronium, etc. So it's very easy right at the start to use volume control because I do not need to think. I just know what's the ideal body weight and multiply by 6, that's the number. If I use pressure control, I do need to think. I need to know what that number is for tidal volume. Say it's 400 milliliters. And then I need to set the pressure control to achieve that particular volume. So it's one additional thing to think about. Not a big deal. Can do it if your preference is that. The other thing that makes me prefer volume control, if I can help it, is that I still fix the tidal volume regardless of the compliance of the lungs. So if the compliance of the lungs worsen, I will still achieve a tidal volume of 6 units per kg. But in pressure control, if the compliance of the lungs worsen, the tidal volume will drop. If the compliance of the lungs improves, the tidal volume will increase if you do not adjust the pressure control. Now, having said that, even though I did say that personally, my preference for simplicity is to start with volume control, there will be times where pressure control is a little bit easier. And this is patient ventilator asynchrony. One very, very painful asynchrony is double trigger, where two breaths come back to back, even though the patient has just asked for one breath. And this is a problem because it's uncomfortable for the patient. And this is also a problem because the two stacked breaths does result in more volume and more pressure. Too much to discuss, but to cut the long story short, in order to reduce the double triggering on volume control, what we generally do is we increase the inspiratory time. That's one. And if it doesn't work, in some patients where the plateau pressure is not very high, meaning that the lung injury is not very severe, we do consider increasing the tidal volumes to, say, 6.5, 7, 7.5, 8 mils per kg, just to prevent the double triggering. And the reason why we do that is because if we have two stacked breaths of 6 mils per kg, we are actually talking 12 mils per kg.
Yep.
Whereas if we have 6.5, 7, 7.5, 8 mils per kg, it's still less than 12 mils per kg. So there's still less volume trauma.
Yep.
Sometimes, despite increasing the flow rate and despite, in addition to that, increasing the tidal volumes, the breath stacking still happens. And because of the ability to better control the inspiratory time and flow rate in pressure control, sometimes switching to pressure control is possible. The only thing to say, last thing to say is, when we switch to pressure control because of double triggering, we must make sure that we have not relieved the double triggering purely because we have now allowed 12 mils per kg.
Okay.
We should only be happy if in switching the pressure control, there's less volume double triggering, even though we still kept the tidal volumes to 6 and a max of 8 mils per kg.
Okay, got it. Okay, thanks so much, Dr. Jason. I think it's been a very practical session where we've looked at the indications for both non-invasive and invasive mechanical ventilation, as well as some of the practical aspects of management of a patient on the ventilator in ARDS. So thanks so much once again, Dr. Jason.
Thanks, Sabine. Thanks.